Immunotherapy has really become the mainstay of therapy for patients with all stages of non-small cell lung cancer, as long as it doesn't harbor a driver mutation. More recently, it's been introduced into the perioperative space, more in neoadjuvant, as part of neoadjuvant therapy prior to surgical resection of the tumor. And so we don't have great biomarkers to show which patients would achieve a pathologic complete response, have a better survival in terms of disease-free survival and overall survival after undergoing surgery. So we were looking for radiomic features. And what does radiomics mean? What we do is we extract textural features from a CT scan using artificial intelligence and deep learning models in order to identify prognostic features and risk stratify patients into different disease groups, or I should say low risk groups. So for this study in particular, what we were looking at are those patients that had surgically resectable disease, patients with primarily stage 2 and stage 3 non-small cell lung cancer, getting neoadjuvant chemotherapy with an immune checkpoint inhibitor. Both nivolumab and pembrolizumab were used in this cohort of patients. And so we had 101 patients. We divided them into a training group for the model, and then we validated the model against a separate subset. They were equally divided in terms of clinical prognostic features as well. And so from the training group, we built the model using LASSO Cox regression analyses. And that was able, that helped us define low and high risk features in terms of disease-free survival. And from that, we were able to risk stratify patients into low and high risk groups based off of disease-free survival. And then we applied the model into the validation cohort. And what we found was there was a significant association with these high risk features. We built a radiomic risk score, and using that median, we were able to divide the patients into low and high risk groups. And when you're comparing high and low risk groups based off of the radiomic risk score, what we found was a hazard ratio of approximately 2.2 to 2.7 between the validation cohort and the training cohort. So this model, what it shows is that it was a positive finding. It could be incorporated into future practice, and more specifically in clinical trial development.